class, I had an opportunity to do an internship with the coroner's office, or the medical examiner here in Coconino County. And I'd never done anything like this before, but we created a special independent study class where we would try to identify cases that she was gaining field experience with and relate them to what we covered in our pathology class. And it was actually a lot of fun because it worked out where it was very, very relevant. So it made me feel wonderful about the class because I felt like it was helping her do what she wants to do. And I think this is the direction that she wants to go. She wants to be a medical examiner. So I got to set up this case a little bit, but now I'm going to tell you about it, and I want you guys to have a little bit of discussion in the room about what your thoughts are. We get to play a crime scene coroner investigator today for just, I'm going to time you. You get like 20 seconds, that's it. But it's kind of neat just to see real life cases that are here in Flagstaff. Okay, so the setup is as it relates to coup and contra coup injuries. So we were talking a lot about blood flow. We're talking a lot about lesions in the brain. Well, trauma. Trauma can obviously happen in a lot of different scenarios. And this head trauma that takes place can cause pretty severe acute and chronic or long-term injuries. Did any of you guys see the movie with Will Smith, Concussion?
Yeah.
If you haven't seen that movie, I gotta be careful. I shouldn't make a political statement. So this isn't a political statement at all, but you'll know where it kind of is going. I'm surprised that he did not win an award for that performance. If you haven't seen the movie, you have to see the movie. It is so good, and it relates. He's an international pathologist, okay? And it's like, you could totally nerd out on this movie, and Will Smith does an amazing job of it. So that is your homework. You gotta watch. You got a Netflix Concussion. Okay. So that's a side tangent, but I'm coming back to it. So in insult to the brain. Okay, and I'll just give a little bit of. I'll come back to it. I'll give a little bit of. So he is investigating chronic trauma in professional football players. Okay. And so you can imagine just and this is based on a true story. This is not like just some I'm sure it was Hollywoodized, but it was based on some real events that took place, and the NFL had to make some changes. So this is one of the reasons that there's no spiking that can take place. You can't drop your head when you tackle. This is one of the reasons because of this case that took place. And so when you have insult to the brain that's repetitive, you can get all sorts of different types of injury that happens to the neural tissue. Now we're talking about parenchymal tissue of the brain. And in these situations, we're talking about blunt force trauma. Even when the player's wearing a helmet, it's still blunt force trauma. Okay? Or with boxers, pugilists, where they're wearing gloves, or even when they're sparring, they're wearing helmets. There's still trauma to the brain. Okay, we'll talk about Muhammad Ali at the very end. There's also open injury that can take place. Open injury could be during surgical insult or surgical repair. Like, so for example, in my mom's case, when they went in and they removed the tumor, there was a resection and there was a tumor cavity that was cut out. And then there's going to be damage as a result of where they cut the tissue out. Okay, so that's surgical resection. But what we really need to understand is that it's not just if a patient strikes their head here, remember that the brain is actually floating in cerebral spinal fluid. So the brain is going to, if I come here and I trip and I hit this way, I've got an injury that happens right here. Well, as it hits this way, it recoils and goes back. And the brain smacks on the back part of the skull, and that's the contra coup injury that takes place. And so with trauma to the brain, blunt force trauma, it's not just at the site of strike, it also can happen on the opposite side as the brain kind of smacks the other cranial side. And so coup is the side that actually strikes first, or where the injury happens, and contra coup is the side that strikes secondarily. Okay, so this patient, here is the case. This is a 408 field work, and this student of mine was on this case here in Flagstaff, and this was between here and Sedona, okay, Coconino County. And it was a 20-year-old Caucasian female tourist who was taking unprescribed antidepressants. She was actually using her boyfriend's Zoloft prescription, fell onto the back of her head, expired on the way to the emergency department with possible pre-death seizure activity. And then the question that I'm asking are, causes of death, is it related to the seizure or is it related to the brain trauma? Okay? And what I want you to talk about is, what would you look at to give you confirmation to determine one or two? Okay? So go ahead and talk about it amongst yourself. This is a real case that took place. It's a very sad story because she's your age. Okay? And we get a lot of tourists coming in. This was a European tourist. And, you know, the sort of unauthorized use is dangerous, and it's not that I'm trying to point out that this isn't a good practice because of sort of ethical reasons. It's more for medical side effects, okay? Because likely the dose was not correct. Or if you're taking Zoloft, you shouldn't pass out. I mean, you're taking too much. It's probably because she's taking the same amount as her boyfriend, who is actually a lot larger than her, okay? So, I mean, there is a reason that we tell patients, don't use someone else's prescription, because there may be side effects, there may be allergies, there may be dosing that's inappropriate. Okay, so it's really, this could really happen. So this is, partly just, educating a broader field of people why it's important to stick to the prescriptions. But go ahead and talk amongst yourselves about one or two. So off in the coroner's office, you're going to be able to do a full autopsy, but you're going to be most interested, I think, in the brain. But let's start out with how would you get a sense of relative dose? She took an antidepressant. On the way to the emergency department, they drew blood, right? They put a line in. They get IVs in. They took a blood sample before they get to the ER or the ED. So what are you going to look for? Maybe pharmaceutical levels in the blood, just determine if the dosing was off. Okay, there's certain metabolites that will show up in the urine, so you can do urine collection and autopsy and pull it straight from the bladder. All right, let's talk about brain. You open up the cranial space, and what are you gonna look for? What do you guys think? What's that?
Swelling.
Swelling. Is there any swelling? Anything else? Hemorrhage. That was yours? You took yours? Okay. Oh, did you guys hear that? So if she fell, maybe she hit the back. And if there's any recoil, maybe there's a contusion injury on the front. So you're going to be looking for gross observations that give you an indication of, maybe how she expired. Or if there's no damage, then maybe we're going to blame the drug and we're going to think she went into some sort of seizure. And that like stopped the heart rate, or maybe she passed out. Okay? All right, so that's a very, very good answer. I feel like you might have been looking over my shoulder. Because the autopsy revealed significant occipital lobe trauma, possible hemorrhage-induced hematoma, and a contusion trauma to the frontal lobe. Nicely done. Cause of death is determined to be a brain trauma-induced death. Okay? Medication could have potentially caused her to be lightheaded and dizzy, and then she fell. But it wasn't determined that the dose was high enough to cause cardiac arrest or stop her from breathing. So she probably passed out, hit her head, and the combination of the coup and the contusion injury is actually what took her life.
Where did she fall from? She was falling.
Standing up. She got out of the car at that overlook between here and Sedona. 89A, if you go down 89A, there's like that overlook. Before you go down the switchbacks, they pulled off there. She got out of the truck, was feeling dizzy, and then fell into the pavement. So between that overlook, 89A, and FMC, she passed. Okay? 20-year-old healthy patient. Nothing else wrong with her. All right, so we brought up a couple of terminologies like hemorrhage and hematoma. So let's talk a little bit more about those in like 2 slides. But before I get there, I just want to talk about diffuse versus focal injury. Because the hematoma and the hemorrhage is a focal injury. But the diffuse is all over the body, or not all over the body, all over the brain. And so a diffuse injury, we call this diffuse axonal injury. A lot of times it happens in absence of blunt force trauma. So it's kind of the counter to what the example is that we're using. And usually it involves acceleration or rotational forces, where here's the structure of a normal axon, and you kind of appreciate this vector force drawn by this arrow of how the axons are actually being rotated in a shear force, causing damage. It may not sever, but it actually will damage, and then eventually that neuron will die. Unfortunately, the most common example that we see is actually in infants, and this is the mode of death of shaken baby syndrome. Because those axons are very delicate. It doesn't take much to actually cause trauma. It doesn't have to cut it all the way off. It just needs to damage it enough that you ruin axoplasmic flow. So you no longer get the movement of nutrition down the axon. But what this young lady died of was a focal injury, not diffuse axonal injury. And these are grossly observable phenomena, meaning that you can see them essentially with the naked eye or the assisted eye, either with imaging, maybe some slight magnification. We're going to look at contusions, concussions, hematomas, and hemorrhages. So the 4 of them are very related to each other. Okay? They're not mutually exclusive. And what I mean by that is you could have a contusion that also has a hematoma associated with it. You could have a hemorrhage that has a hematoma associated with it. Okay, so there's 4 categories, but they're not mutually exclusive. You could have overlapping or dual characteristics that show up in one clinical event. Now, concussion is the name of this Will Smith movie. And It's one of the most common that we see. And now there's this heightened level of awareness amongst impact sports, like with football and hockey, and sports that young kids are playing, these contact sports where the head can actually get traumatized. So what is a concussion? There's a reversible, altered consciousness. You don't see a contusion. We haven't defined contusion yet, so what the heck is a contusion? That's where you actually have damage or a laceration to the brain tissue. So you don't have that in concussion. You likely have some amount of amnesia or a loss of memory. It could be short-term. It could be a loss of memory of the event. Okay? Many of you that have had a concussion know you have a concussion because all of a sudden the lights went out and you woke up like hours later or minutes later and you don't know what happened. Right? You ended up in your mom and dad's car, or now you're on the couch. Like, how did I get here? That's amnesia. Okay, so that's evidence that you had a concussion at some level. The pathogenesis is really unknown, but likely it's due to shocking of the neurons. Okay? You can kind of see the breakdown in children, and the largest breakdown, and I can attest that this graph is probably correct in my house, is because of a fall. Right? Kids they fall all the time. So I've had a couple of concussions in our house due to falls, and one child in particular, and very nervous that CPS was going to get called because we keep bringing her in for these concussions. But the medical care workers obviously know the graph, and it's more likely that it was a fall and not the dad hit her, right? The fall rate in children is starting to be trumped, though, by football-related injuries or contact sport-related injuries with young kids. Okay? All right. So what's a contusion? What is that? You said there's no contusion, so show me what I don't see in a concussion. Well, if you have a concussion, you're not going to take the brain out and look to see if there's a contusion. Okay? But you would see, if you saw imaging of it, you would actually be able to appreciate there's a lesion down here, okay, there's a lesion right here, there's a lesion right here. So these are bruising, a laceration, or even necrosis of the brain tissue. That's what a contusion is. Now, if we continue to move on down the categories, we get into a hematoma. So with a concussion, it's really the only category where it can be mutually exclusive, where if you have a concussion, you're likely not going to see anything else. But if you have a contusion, there may be amnesia associated with it, but it's not the concussion that you're worried about. You're more worried about the laceration or the bruising of the brain. With a hematoma, now we're moving into stages of severity, increasing severity. With the hematoma, we actually get a localized accumulation of blood. This is a pooling of blood that clots off. A bruise, really, where there's a vessel that has been compromised and the blood has left the vascular system and it's clotted off. So we've got a localized accumulation of blood. We have three main types: epidural, right, above the dura, subdural below it, and then subarachnoid. And the subarachnoid is the one that you commonly see associated with the contusion. So if you have a contusion and you're going to see a hematoma, it's usually a subarachnoid hematoma. So if you look over here on the right, and we'll get to this picture. This is a split. This is showing the epidermal hematoma on your left. This is showing the subdermal hematoma on your right, or the patient's left. And you can appreciate that when this lining is torn, we've compromised the venous circulation of really that arachnoid villus. And so usually a subdermal hematoma is going to be venous blood. And then over here on the patient's right, or your left, when you tear this tissue here away, you're compromising the artery. This is specifically the middle meningeal artery is ruptured. And so this is usually an arterial blood source for an epidural hematoma. And then if you look down here, you can appreciate this is bleeding that's taking place as far as an intracerebral hemorrhage. And then here is a subarachnoid hemorrhage. We're going to get to hemorrhage here in the next slide. This picture, the big gross one, is an epidermal hematoma. The reason it's so visible is because it's at the very superficial portion. And so you're seeing all the clotted blood that's sitting basically on top of the brain with this epidural hematoma. And this is a arterial flow that's taking place. So cerebral hemorrhage, we've alluded to cerebral hemorrhage. So you can have a hemorrhage and a hematoma because they kind of go hand in hand, right? An active hemorrhage means it's still bleeding. As it stops bleeding, it develops a hematoma. Make sense? So there could be areas that are clotted blood, there could be areas that are still being perfused, but the hemorrhage is very, very concerning because if it's an active hemorrhage, it means the patient is still losing blood volume. And so you actually need to neutralize or prevent that blood flow from being compromised. So the most common reason for a cerebral hemorrhage is the vessel itself rupture. It's a little bit obvious. How does it rupture? Well, it could rupture because of high blood pressure, hypertension. Could rupture because of a malformation that occurs. These are very common. They're genetic malformations that occur in all of us. You can kind of see a pattern here. The most common malformation is at the top of this circle of Willis, right between this anterior communicating artery as it goes over to the anterior cerebral artery. So about 40% of the malformations actually occur right here and lead to this saccular aneurysm. Saccular aneurysm is where the wall of the blood vessel loses its integrity. It's pressurized, and so it kind of balloons out. And as it balloons out, it's at risk of rupturing, and if it ruptures, then you're going to have an active hemorrhage. And so here is a picture of this location of this anterior communicating artery where the most common hemorrhage takes place, and this is a saccular aneurysm right here. Here is a picture of an active rupture that took place, and now you have a hematoma. Last but not least, trauma with contusion to the parenchymal tissue, and that severs the vessel. That will create an active hemorrhage. So we actually have some ways that we can treat these aneurysms as well as hemorrhaged aneurysms that have actually ruptured. And we can do that using endovascular techniques, but these are the types of different examples of the saccular aneurysms. We would come in with that device that I showed you earlier. You would enter up through a leg vessel or an arm vessel. You would reline the inside lining of that neurovascular vessel, and you would reestablish blood flow to prevent the blood from exsanguinating outside of the vessel. So this is that saccular aneurysm from that previous picture, just in higher magnification. Here is another example of a saccular aneurysm. Right, so this is the vessel right here. It should come up and it should bifurcate this direction and bifurcate this direction. And right here at that branch is the weakness, and this is where it bulges out. Histology of an aneurysm. So this is the vessel feeding. It's supposed to turn and go up here to the right. So that white space is the lumen. And then this is the aneurysm sac as it's ballooning out. So you kind of appreciate kind of three different views of saccular aneurysms that kind of give you an appreciation. And they're called saccular because they're look like a bulge. Okay. In our last remaining time, we're going to kind of cover some other very top level, but at least giving you some exposure to some of these other types of central nervous system disorders. So the first one that you do cover, we talk about in 201, is meningitis. This is an infection of the leptomeninges, The leptomeninges are the space, the combination of the two spaces, the dura and the arachnoid artery. So either one of those tissues could be infected with a bacteria, with a virus, or with a fungus. And on a lumbar puncture, right, so in the back, into where the cerebral spinal fluid is, you can actually pull off CSF and you can test for which one it is, how you're going to treat it. Okay? So you'll come in from a lumbar puncture instead of coming in through the brain. I think that probably makes sense, but sometimes I feel like I need to explain that. So because the CSF flows throughout the entire central nervous system, that CSF is down here in the spinal cord, and that's contiguous with the CSF that's floating around in the brain. Now, the two most common types that we run into are bacterial, and the bacterial infections are usually divided up between younger patients and older patients. And so the streptococcal pneumoniae is the bacteria that typically affects pediatric and geriatric. Streptococcal pneumonia, the first one that's listed. And then in this room, in the college age and the military age, we usually see this Neisseria is the culprit for sort of late teens to maybe like middle age. Okay? And so just understanding that there's different bacteria that are most common gives you the ability to target the appropriate types of therapy. And so in this picture, what you're seeing is you're seeing a bunch of pus as a result of this bacterial infection. This is the bottom of the brain, so you're looking at sort of a undercarriage view. You're looking at the bottom of the brain. Here's the cerebellum down here, and this white pus is due to that infection, that meningitis infection. Okay? Pretty common, relatively simple to treat. If it's left untreated, it's lethal. And people that have meningitis start acting a little cuckoo. They start acting not like themselves. They start acting irritable. They might get aggressive. And so people have been misdiagnosed to have meningitis for having sort of mental behavioral problems. Okay, and then they get tested and find out that it's meningitis, and then we treat it appropriately, and everything turns out just fine.
Is that due to the inflammation of the meninges? Like
Yes.
pressure?
Yeah, so that the whole brain is becoming inflamed because of the infection, and so that's causing cytotoxic edema, right? Instead of vasogenic, so that could actually put pressure and cause cerebral edema, and then it starts putting pressure on the personality centers in the cerebral cortex, and that can change and alter behavior. Okay, the next one up is, I think it's Creutzfeldt-Jakob. Yes, Creutzfeldt-Jakob. So Creutzfeldt-Jakob is a very interesting disease. You're going to learn more about it in infectious if you take it with Dr. Nieto. And so I just want to, we try hard not to overlap too much, but I want to, there is obviously, overlap. So this is a prion disorder. And so you and I all have prions within our brain tissue. Prions are normal cellular proteins that exist in certain formats, and when they become mutated, they start to clump or agglutinate in awkward formation. And as they agglutinate, so you can see here, this is the aggregates that are forming here by the green mutated prion. The normal prion is shown here sort of in this pinkish color, but as it mutates in patients, it starts to clump. And as it clumps and precipitates, it actually takes residence in neural tissue. So this is an immunohistochemistry on the lower left, stained for prions. And the prions are in the brown. So you can kind of appreciate where the Creutzfeldt-Jakob prions are testing positive in this neural tissue. Over here, is the result that takes place at some time in the future as this organization of mutated clumped prions, this tissue starts to reorganize into vacuole structures, open space, vacuolar structures that are hollow. And so if you can kind of appreciate the white circles are the void tissue. They used to have functional tissue. And this little inset is a zoom in of this oval. This is very similar to the way adipose or fat tissue looks, histological. Is you get these large open vacuoles. And because of its appearance, these cytoplasmic vacuoles, as they create these wide open void spaces, you push out the neurons and the neurons start to die. And so the terminology, as a result of the way it looks, is referred to as spongiform. So this is a spongiform encephalitis disease that makes the tissue look like an open sponge. And it exists pretty commonly in cattle. And so in cattle, we refer to it as mad cow disease. It's very rare for it to occur in humans all by itself. In fact, people that acquire a genetic mutation of the gene that codes for an abnormal prion protein only accounts for 5 to 10% of all Creutzfeldt-Jakob cases. The other 90 to 95% is from eating infected meat. Okay? So we haven't had an issue in a long time. In fact, the last time I remember there being a big issue was probably about 11 or 12 years ago. Okay? So all of you are probably too young to even care. Okay? Because McDonald's was still your restaurant of choice. Now you don't even want to touch it, I imagine. But there was about 11 or 12 years ago, there was an outbreak of infected cattle, primarily in the UK. And I was traveling a lot, so whenever I would go over to London, we would specifically not eat beef. And so why would eating beef be a problem? Well, it's really because of, so I'm going to turn those of you that are thinking about it being vegan, I'm going to turn you into vegans here in a second. The practice at the slaughterhouse, you bring the cattle in, and then you bring down this mallet really fast, and it punches a hole in the side of their head. And that's how they humanely slaughter cattle. And unfortunately, it's not super clean, as you can imagine. And so some of that contaminated neural tissue gets into everything else, including the meat that you and I might eat. And so that's why it's a very regulated industry by the Food and Drug Administration in this country. We've never had a Creutzfeldt-Jakob issue in this country, thankfully. But it's actually happened in Australia, it's happened in Europe. I do not believe it's happened in Canada, but I could be wrong about that, okay? So that's Creutzfeldt-Jakob. MS, multiple sclerosis. So we only have MS, and then we've got Alzheimer's, and then we're finishing out with Parkinsons. MS we've talked about. This is a type 4 hypersensitivity. And the problem is the role of cytotoxic T cells. And it's a demyelinating disease where the cytotoxic T cells that are not self-tolerant, that they're self-reactive, they seek out and destroy the myelin as well as the oligodendrocytes and the Schwann cells that manufacture the myelin. And what they leave behind is actually either a bare neuron or a fibrotic gliosis scarring. And that slows down the action potential signal as it transcends down the neuron. So the etiology is very confusing. But some of the statistics show that women are actually twice as likely to develop MS than men. It's more common the further away from the equator the population gets. And so there's this environmental theory of how sun exposure is beneficial to preventing these leaky or these self-reactive CD8 cells from getting out and targeting your myelin. So in the Nordic regions, the MS rates are actually much higher than they are in regions that are near the equator. Now, is there environmental, or is that because those genetic populations are uniquely different? Well, the genetic populations are definitely uniquely different, but we can eliminate, and apparently there's a lot of epidemiological data that suggests that sun exposure is a great way to mitigate MS onset. Okay? And it's one of the therapies that's actually looked at. So clinically, there's usually a steady decline in functionality. There's unilateral vision loss in the patient. There's sensory as well as motor impairment, including bladder control, which is lost at the end stages. And this picture down in the bottom is showing a scarring that takes place within a patient around the occipital horn of the lateral ventricle. And so you see this red tissue? So the tissue should either look white, like the white matter, or it should look grayer, or not as white, like the gray matter. But this reddish color is the plaque or the scar that's forming where white matter tissue used to be, myelinated tissue used to be. And what you're appreciating and what you're seeing in this fresh isolated prep at autopsy is an end-stage MS patient where a lot of the white matter was lost, and it was replaced with a gliosis or a scar. Dementias. So if you watch Dr. Miller's lecture, his guest lecture that's on YouTube, you'll see him talk an awful lot about different types of dementia. Well, the most prevalent dementia that takes place, the most common, is Alzheimer's. It's not the only one. It's the one we always talk about because it's the most common. So Alzheimer's-induced dementia is one of the most common forms of dementia. And the tissue reorganizes. It reorganizes very similar in a way to the way this Prion disease takes place that we talked about in Creutzfeldt-Jakob, although they are mutually exclusive processes. And you form what are called these beta amyloid plaques, or these neurofibrillary tangles. And as the patient gets older, they're at greater risk of developing Alzheimer's, right? It's affectionately referred to as old-timers disease, because the number one risk factor for developing Alzheimer's is age. It's a old person's disease. Some other common risk factors, or highly impactful risk factors. Trauma. Previous history of trauma. Okay? And if you watch this movie called Concussion with Will Smith, you'll kind of see this play into the theme of the story. So what happens is you get these beta amyloid plaques as the amyloid precursor protein starts to dissociate. You get the alpha-beta aggregates, and then you get these amyloid fibers. And histologically, here are the neurofibrillary tangles. And then this is histology stain. It's showing your beta amyloid plaques organizing here in the middle, and then a different view of beta amyloid plaques organizing here. So a plaque is a scar. And so it forms a scar in tissue, neural tissue that used to be functional. And so now it's no longer functional. And if it targets memory centers, now the patient sort of loses their long-term memory, or their short-term memory, as it might be. And so that's the video of these two twin brothers that's posted on YouTube. You'll see one that does a really great job of trying to trick the examiner into thinking that it hasn't really had any neurological deficit. So another risk factor, which is a little controversial, is educational level. So in patients that have higher levels of education, Alzheimer's or diagnosed Alzheimer's has a lower percentage. But we don't understand if it's because you're keeping your brain sharper, you're doing Sudoku all the time, and you're keeping your brain sharper. There's a lot of data that shows that's a good, what's that one website, Luminosity? You see these ads for Luminosity? So keeping your brain sharp or having neurological function that's high may allow you to have compensatory mechanisms where you can figure things out, or you can actually kind of fool people into thinking that you haven't really forgotten anything. Okay? So age, it is a little bit more common in females than it is in males. And prior trauma, and then some element of education. Okay? And we don't know really if that's use it or lose it, or if that's because you're able to have a higher level, so as you deteriorate, it's harder to detect if you're having neurological deficit. Now, the last disease that we're going to characterize is Parkinson's. So at my mom's hospital, there's this Muhammad Ali Center, so I had to get this photo, because he wouldn't sign, because he's no longer here. But I got a picture with Muhammad, the great Muhammad Ali. So Parkinson's disease. So Muhammad Ali suffered from Parkinson's disease. And really, the issue is with the substantia nigra. So this is a normal substantia nigra. This is part of the basal ganglia in the midbrain. And this is a depigmented. See how this one looks whiter, and this one has darker shadings here? The darker shadings are areas that are actually cranking out dopamine. And what dopamine does is it has an activity to mitigate unwanted motor movements. And so when dopamine is not on board, you start developing these tremors. Okay? And in Parkinson's patients, like with some of the other diseases, neurological diseases, the substantial nigra is susceptible for trauma. And so in sporting events or in activities like with Muhammad Ali, the thought was that the boxing career brought on or accelerated his initiation of Parkinson's, excuse me, I keep saying Parkinson's. But all of these neurological diseases, really other than Creutzfeldt-Jakob and multiple sclerosis, can be associated with long-term chronic exposure to trauma. The symptoms are diminished facial expression, a stooped posture. I don't know if you've seen pictures of the late Muhammad Ali. Later in his life, he was kind of really stooped over, okay? And he wasn't quite that old, right? And he was in great physical shape as an elite boxer. Slowness of voluntary movement, shortened gait, and essential tremor, or an underlying tremor everywhere. It could actually be not just the hands, it could be the whole body that tremors. And it's because the thought is that dopamine is no longer being released. Okay? So that caps out today's lecture. Don't forget that there's 2 post quizzes on Friday that you're responsible for. Okay? Have a great week.